Welcome. This is our part today from Egyptian Society of Cardiology review course. I am Tamer Moustafa, Professor of Cardiology in Zagreb University, and our lecture today will be about the pharmacological management of hypertension. For every category of patients, whether high normal, grade 1, grade 2 or 3, it is basically to go with lifestyle changes. Number one, when to initiate the office blood pressure level. In patients with grade 1 hypertension, we should go immediately for drug treatment in the high or very high risk patients with cardiovascular disease, renal disease or hypertensive mediated organ damage. Of course, grade 2 or grade 3, you can go immediate for drug treatment in all patients who are aiming to reach the blood pressure goal within 3 months. Here is a summary of the office blood pressure threshold for treatment. We have 3 age groups: age from 18 to 65, and 65 to 79, and from 80 and more. The target of hypertension, whatever alone or with other diseases like diabetes, CKD, coronary artery disease, stroke or TIA, for systolic blood pressure when it is over 140 for the first two age groups. And if patient is aged 80 or more, we start over 160. About the diastolic blood pressure, the cut is for all categories is 90. So if patient with age 18 to 65, it is class 1A to start your treatment over 140 overnight. The same for the other age group of 65 to 79, but over 80, you can start over 160 over 90. And the diastolic pressure will be 90. For very high risk group, you can consider the margin of 135 over 85 to be considered, but this is class 2B level of evidence A. We should know what is the compelling and possible contraindication for the specific antihypertensive drugs. For example, the diuretics, like thiazide or thiazide-like type, example clozalidone and indapamide. The compelling is gout, and we should consider possible complication like metabolic syndrome, glucose intolerance, pregnancy, hypercalcemia or hypokalemia. The beta blockers, not all the beta blockers. There is a difference between the new generations and old generation of beta blockers. Overall, the patient with active or reactive asthma, patient with high grade of AV block, patient with bradycardia with heart rate less than 60 beats per minute, this is a compelling contraindication. And we should consider metabolic syndrome, glucose intolerance, athletes and physically active patients. For calcium channel blocker, there is no completing contraindication, but we should take care of tachycardia. We don't prefer to use in heart failure, especially with reduced ejection fraction and patient with class 3 or 4 and with pre-existing severe leg edema. For verapamil and the lithiazime, we consider the EV block. We consider presence of severe left ventricular dysfunction with ejection fraction less than 40% and bradycardia with heart rate less than 60 beats per minute. For ACE inhibitors and ARPs, compelling contraindication is pregnancy, previous angioneuritic edema, presence of hyperkalemia with potassium level more than 5.5, and bilateral renal artery stenosis. The possible is women of childbearing potential without reliable contraception. Here the guidelines how to proceed in management by drugs your patient with uncomplicated hypertension. The initial therapy is to go with dual combination with one pill using ACE inhibitor or ARP plus CCP or diuretics. If you not reach the target, go to step 2 with triple combination in one pill, ACE inhibitor or ARP plus CCP plus diuretic. Step 3 is to go to pills using triple combination, adding spironolactone or other drugs like other diuretic, alpha blocker and beta blocker. You should remember the patient who in need for immunotherapy are 2 categories. Patient with low risk grade 1 hypertension with systolic blood pressure less than 150 and very old patient, over 80 or frailer patient, you can go with monotherapy. And beta blocker can be considered at any treatment step when there is a specific indication for their use, like heart failure, angina, post-myocardial infarction, presence of AF, younger women with or planning for pregnancy. Second category is patient with hypertension and coronary artery disease. There is one of three options in step 1, to use ACE or ARB plus beta blocker or CCP, or CCP plus diuretic or beta blockers, or beta blocker plus diuretic. And step 2, we can go for triple combination of the above, and in step 3, we can add spironolactone, other diuretic or alpha blocker. In patient with hypertension and CKD, the initial therapy is to go with ACE inhibitor or ARB plus CCP, or ACE inhibitor or ARB plus diuretic, and we can use or prefer use of loop of diuretic. And step 2, we go for 3 drugs, ACE or ARB, calcium channel blocker, plus diuretic or loop diuretic. And step 3, you can add spironolactone, other diuretic or alpha blocker or beta blocker. Remember the cautious 4 level of potassium level, especially when adding spironolactone. And patient with CKD, we should consider them about the use of ACE inhibitor or ARB if a rise in the serum creatinine by more than 30% to evaluate the potentiality of possible renal vascular disease. Patient with hypertension and reduced ejection fraction. The initial therapy is ACE or ARB plus a diuretic or loop diuretic plus beta blocker. And step 2 is to add MRA. When the antihypertensive therapy is not required in patient with heart failure with reduced ejection fraction, the treatment should be prescribed according to the ESC heart failure guidelines. Patient with hypertension and AF, the initial is dual combination using ACE or ARB plus beta blocker or non-dihydropyridine CCP or beta blocker plus CCP. The step 2 is ACE inhibitor or ARB plus beta blocker plus DHP CCP or diuretic, or beta blocker plus DHP CCP plus diuretic. We should add oral anticoagulation according to Schatz-Fosk score unless contraindicated. And the routine use of a combination between beta blocker with non-dihydropyridine CCPs like verapamil or diltiazem is not recommended due to a potential marked reduction in the heart rate. This is the summary of drug treatment strategy. You choose your drugs according to the presence of hypertension alone, presence of associated coronary artery disease, CKD, AF, or heart failure with reduced ejection fraction. About the guidelines, from the all antihypertensive drugs, the 5 groups can be used to reduce effectively the blood pressure and cardiovascular events proven in the randomized controlled trials, and this is class 1A. The combination of 2 drugs is preferred, especially presence of ACE inhibitor ARB with CCP or diuretic, and this is class 1A. Beta blocker can be used in any time with specific clinical situation, example angina, post-myocardial infarction, heart failure, or the need for heart rate control, and this is class 1A. It is better to use a combined 2 drugs in single pill for more compliance, except for frail older patients and those at low risk with grade 1 hypertension, particularly if systolic blood pressure less than 150, this is class 1B. What is very important is the combination of 2 RAS blockers is not recommended. This is class 3 level of evidence A. The device-based service for hypertension, use of device-based service is not recommended for routine treatment of hypertension unless in the context of clinical studies and randomized control trials until further evidence regarding their safety and efficacy become available. Now it is class 3 level of evidence B. Here is the resistant hypertension, the characteristics, secondary causes, and contributing factors. Remember that there is a demographics in these patients: older age, obesity, more common in black people, excess dietary sodium intake, high basal blood pressure, and the chronicity of uncontrolled hypertension. And there is concomitant diseases like LVH or CKD, diabetes, atherosclerotic vascular disease, aortic stiffening, and isolated systolic hypertension. Also, secondary resistant hypertension, the more common causes like primary hyperaldosteronism, atherosclerotic renovascular disease, sleep apnea syndrome, and CKD, and the drugs prescribed by the patient as oral contraceptives, sympathomimetic agents like decongestant, non-steroidal anti-inflammatory drugs, cyclosporin, risopatin, steroids like prednisolone and hydrocortisone, and some cancer therapies, all precipitate for secondary resistant hypertension. For resistant hypertension, it is defined to have optimal doses or best tolerated doses of an appropriate therapeutic strategy and should include a diuretic. Typically, we use ACE inhibitor or ERP with a CCP and a thiazide or thiazide-like diuretic, which fails to lower clinic systolic and diastolic blood pressure less than 140 and 90, respectively. The inadequate control of blood pressure has been confirmed by ambulatory blood pressure monitoring or home blood pressure monitoring, and after exclusion of various causes of pseudo-resistant hypertension, especially poor medication adherence and the causes of secondary hypertension. This is a suspicion for coronary secondary disease. A younger patient less than 40 years with grade 2 hypertension and onset of any grade of hypertension in childhood. Acute worsening hypertension in patient with previously documented chronically stable normal tension, resistant hypertension, severe grade 3 hypertension, or a hypertension emergency, presence of extensive hypertensive mediated organ damage, clinical or biochemical features suggestive of endocrine causes of hypertension or CKD, clinical feature suggestive of obstructive sleep apnea, and symptoms suggestive of leukocytoma or family history of leukocytoma. Remember that the common causes of obstructive sleep apnea in 5 to 10%, renal parenchymal disease in 2 to 10%, renovascular disease in 1 to 10%. From the endocrine disease, there is leukocytoma, Cushing, and hyperparathyroidism less than 1%, while primary aldosteronism from 5 to 15% and coarctation of aorta less than 1%. You should know it before proper treatment of hypertension. The medications and other substances that may increase blood pressure, like oral contraceptive pills, especially estrogen containing, diet pills, nasal decongestant, stimulant drugs like amphetamine and cocaine, licorice, immunosuppressive medications, anti-androgenic cancer therapies, and other drugs and substances that may raise the blood pressure like anabolic steroids, erythropoietin, the use of non-steroidal anti-inflammatory drugs, and herbal remedies. What are the drugs used in emergency which require immediate blood pressure lowering with intravenous drug therapy? For malignant hypertension with or without acute renal failure, we need several hours to reduce mean arterial blood pressure by 20 to 25%. First line are labetalol and nicardipine. Alternative are natoproside or urapidil. In hypertensive encephalopathy, we need immediately reduce of MAP by 20 to 25%. We can use labetalol and nicardipine. Alternative are natoproside. In acute coronary event, we need immediate reduction of systolic blood pressure, not mean, to less than 140 using nitroglycerin or labetalol, and alternative is urapidil. In acute cardiogenic pulmonary edema, we need immediately reduction of systolic blood pressure to less than 140. We can use natoproside or nitroglycerin with a loop diuretic. The alternative is urapidil with loop diuretic also. In acute aortic dissection, we need immediately reduce the systolic blood pressure to less than 120 and heart rate to less than 60. We can do it using esmolol and the natoproside or nitroglycerin or nicardipine. The alternative is labetalol or metoprolol. In eclampsia and severe preeclampsia and HELP syndrome, we need immediately reduce the systolic blood pressure to less than 160 and the diastolic to less than 105 using labetalol or nicardipine and the magnesium sulfate, and the alternative we can consider delivery. Drug types, doses, characteristics for treatment of hypertensive emergencies. Esmolol, it acts within 1 to 2 minutes, act for 10 to 13 minutes, starting dose 0.5 to 1 milligram per kg intravenous bolus, then 50 to 300 microgram per kg per minute intravenous infusion. Metoprolol, it acts with 1 to 2 minutes, but duration of action is 5 to 8 hours. We start with 2.5 to 5 milligram intravenous bolus over 2 minutes, and they may repeat every 5 minutes to a maximum dose of 15 milligram. Labetalol, it acts within 5 to 10 minutes, act for 3 to 6 hours. We start from 0.25 to 0.5 milligram per kg as intravenous bolus, then 2 to 4 milligram per minute intravenous infusion until goal blood pressure is reached, and thereafter 5 to 20 milligram per hour. Phenoldopam, it acts within 5 to 15 minutes, act for 30 to 60 minutes. We start from 0.1 microgram per kg per minute intravenous infusion, and we can increase every 15 minutes with 0.05 to 0.1 microgram per kg per minute increments until blood pressure is reached. Clevidipine, it acts within 2 to 3 minutes for 5 to 15 minutes. We give intravenous infusion of 2 milligram per hour and increase every 2 minutes with 2 milligram per hour until goal blood pressure. And the nicardipine, it acts within 5 to 15 minutes, act for 30 to 40 minutes. We give 5 to 15 milligram per hour intravenous infusion. Starting dose is 5 milligram per hour. We increase every 15 to 30 minutes with 2.5 milligram until goal blood pressure, thereafter decrease to 3 milligram per hour. Nitroglycerin, it acts within 1 to 5 minutes, act for 3 to 5 minutes. We can give from 5 up to 200 microgram per minute as intravenous infusion with 5 microgram minute increase every 5 minutes. Nitroprusside, it acts immediately and act for 1 to 2 minutes. We can start with 0.3 up to 10 microgram per kg per minute. Intravenous infusion can increase by 0.5 microgram per kg per minute every 5 minutes until goal blood pressure. Enalaprelate, it acts within 5 to 15 minutes, act for 4 to 6 hours. We can give 0.62 to up to 1 to 25 milligram as intravenous bolus. Urapidil, it acts within 3 to 5 minutes, act for 5 to 6 hours. We start from 12.5 to 25 milligram as intravenous bolus, then from 5 up to 40 milligram per hour as a continuous infusion. Clonidine, it acts within 30 minutes, act for 4 to 6 hours. We can give 150 up to 300 microgram as intravenous bolus over 5 to 10 minutes. And phentolamine, it acts within 1 to 2 minutes, act for up 30 minutes. We can start with 0.5 to 1 milligram per kg bolus or 550 to 300 microgram per kg per minute intravenous infusion. Here is what about the management of white coat hypertension. White coat hypertension, it is recommended to implement lifestyle changes aimed at reducing the cardiovascular risk as well as regular follow-up with periodic out-of-office blood pressure monitoring. In patients with white coat hypertension, drug treatment may be considered in patients with evidence of hypertensive mediated organ damage or in whom the cardiovascular risk is high or very high, and this is class 2B level of evidence C, but routine drug treatment is not indicated. This is class 3 level of evidence C. Masked hypertension, it is the reverse of the white coat hypertension. In masked hypertension, lifestyle changes are recommended to reduce the cardiovascular risk. with regular follow-up, including periodic out-of-office blood pressure monitoring. This is class 1C. Antihypertensive drug therapy should be considered in masked hypertension to normalize the out-of-office blood pressure based on prognostic importance of the out-of-office blood pressure elevation, and this is class 2A level of evidence C. The antihypertensive drug up titration should be considered in treated patient whose out-of-office blood pressure is not controlled. بمعنى ان الماسكed uncontrolled hypertension because of the high cardiovascular risk of this patient, and this is class 2 level of evidence C. In hypertension in pregnancy, in whom with gestational hypertension or pre-existing hypertension superimposed by gestational hypertension, or with hypertension and subclinical organ damage or symptoms, initiation of drug treatment is recommended when systolic is over 140 or diastolic is over 90. This is class 1C. In all other cases, initiation of the drug treatment is recommended when systolic is over 150 or diastolic is over 95. Methyl dopa, labetalol, and CCPs are recommended as drugs of choice for the treatment of hypertension of pregnancy. But ACE inhibitors or ARBs or direct renin inhibitors are not recommended during pregnancy. This is class 3 level of evidence. Management: systolic blood pressure is over 170 and diastolic is over 110 in a pregnant woman is an emergency, and admission to hospital is recommended. This is class 1C. In severe hypertension, drug treatment with intravenous labetalol or oral methyl dopa or nifedipine is recommended, class 1C. The recommended treatment for hypertension crisis is intravenous labetalol or nicardipine and magnesium. In preeclampsia associated with pulmonary edema, nitroglycerin given as an intravenous infusion is recommended. In women with gestational hypertension with mild preeclampsia, delivery is recommended at 37 weeks, and it is recommended to do the delivery in preeclampsia with adverse conditions such as visual disturbances or homeostatic disorders. Hypertension in ethnic groups. It is recommended that two-drug combination, usually as a single pill, is used as initial therapy for most Black patients. This is class 1C. In Black patient, initial antihypertensive therapy should include a diuretic or a CCB, either in a combination or with a RAS blocker, and this is class 1B. In other ethnic groups, blood pressure lowering treatment may be based on the core treatment algorithm. Treatment strategies in people with diabetes. Antihypertension drug therapy is recommended for patients with diabetes when the office blood pressure is over 140 over 90. In people with diabetes, we should target the systolic blood pressure to 130 and lower if tolerated, but not lower than 120. In older people aged from 65 and more, to target the systolic blood pressure 130 to 139, and to target diastolic blood pressure to less than 80 but not lower than 70. These all are class 1. It is recommended to initiate treatment with a combination with RAS blocker with CCP or Cyzate-like diuretic. This is class 1A, but simultaneous administration of two RAS blockers with ACE or ARB or ARBs is not indicated, class 3. Patient with CKD. In patient with CKD, the target to start your treatment is office blood pressure over 140 over 90. In patient with diabetic or non-diabetic CKD, it is recommended to lower the systolic blood pressure to a range of 130 to 139. This is class 1A. Individualized treatment should be considered according to its tolerability and the impact on renal function and electrolytes. RAS blockers are more effective in reducing albuminuria than other antihypertensive agents and are recommended as a part of treatment strategy in the hypertensive patient in the presence of macroalbuminuria or proteinuria, and this is class 1A. The combination of RAS blocker with CCP or a diuretic is recommended as initial therapy. This is class 1A, but combination of two RAS blocker is not recommended class 3. Patient with coronary artery disease, it is first to target systolic blood pressure to be 130 or less, and if tolerated, but not less than 120. In older patient aged from 65 and more, to target systolic blood pressure to be within 130 to 140, and to target diastolic blood pressure to be less than 80 but not less than 70. In hypertensive patient with history of myocardial infarction, beta blocker plus RAS blockers are recommended as part of treatment. And in patient with symptomatic angina, beta blockers and or CCPs are recommended. Patient with heart failure or left ventricular hypertrophy. In hypertensive patient with heart failure with reduced or preserved ejection fraction, the blood pressure lowering treatment should be considered if the blood pressure is over 140 over 90. In patient with heart failure with reduced ejection fraction, it is recommended that blood pressure treatment compromises an ACE inhibitor or ARB plus a beta blocker and a diuretic and or MRE is if required. This is class 1A. Dihydropyridine CCBs may be added if the blood pressure control is not achieved, but this is class 2B. In patient with heart failure with preserved ejection fraction, blood pressure treatment threshold and the target values should be the same as patient with heart failure with reduced ejection fraction. And because no specific drug has proven its superiority, all major agents can be used. In patients with left ventricular hypertrophy, it is recommended to treat with a RAS blocker in combination with a CCP or a diuretic, and systolic blood pressure should be lowered to be in the range between 120 and 130. In patients with acute intracerebral hemorrhage, the immediate blood pressure lowering is not recommended for patients with systolic blood pressure less than 220, and this is class 3 level of evidence A. In patients with systolic blood pressure more than 220, careful acute blood pressure lowering with intravenous therapy to be less than 180 should be considered, and this is 2A. In acute ischemic stroke, routine blood pressure lowering with antihypertensive therapy is not recommended, with exceptions. This is class C. In patients with acute ischemic stroke who are eligible for intravenous thrombolysis, blood pressure should be carefully lowered and maintained to be less than 180 over 105 for at least first 24 hours after thrombolysis, and this is class 2A. And in patients with markedly elevated blood pressure who don't receive fibrinolysis, drug therapy may be considered based on clinical judgment to reduce blood pressure by 15% during the first 24 hours after stroke onset. In hypertensive patients with acute cerebral event, antihypertensive treatment is recommended immediately for TIA, this is class 1A, after several days of ischemic stroke, this is class 1A. In all hypertensive patients with ischemic stroke or TIA, the systolic blood pressure range of 120 to 130 should be considered, this is class 2A, and the recommended antihypertensive drug strategy for stroke prevention is a RAS blocker plus a CCP or a thiazide-like diuretic. Patient with EF, we should consider beta blocker and calcium channel blocker. About the use of anticoagulants, we should consider the Chats-Vasquez score to add anticoagulant. And lastly, I wanted to mention that therapeutic strategies in hypertensive patients with lower extremity artery disease, the blood pressure lowering treatment is recommended to reduce the cardiovascular risk, and this is class 1A. A combination of RAS blocker, CCP, or a diuretic should be considered as initial therapy, and beta blockers may be considered, especially the vasodilator beta blockers, but this is class 2B. What about management of perioperative patient with hypertension? It is recommended that newly diagnosed hypertensive patients who are scheduled for elective surgery should be preoperatively screened for hypertensive mediated organ damage and cardiovascular risk. It is recommended to avoid large perioperative blood pressure fluctuations during the perioperative period. Non-cardiac surgery may not be deferred in patients with grade 1 or 2 hypertension, with systolic blood pressure less than 180 and diastolic less than 100. Preoperative continuation of beta blockers is recommended in hypertensive patients on chronic treatment with these drugs, but abrupt discontinuation of beta blocker or the centrally acting agents, example clonidine, is potentially harmful and it is not recommended. It is class 3 level of evidence B. Transient preoperative discontinuation of RAS blocker should be considered in patients with hypertension undergoing non-cardiac surgery. This is class 2A. The last to mention, the intervention that may improve drug adherence in hypertension, which is a very, very important issue to control the blood pressure with drugs, is about 4 levels. There is a physician level, a patient level, drug treatment level, and health system level. And thank you very much.